the Myositis Association's Ask the Doc webinar series. My name is Rachel Bromley, and I am TMA's Senior Manager of Patient Education, Support, and Advocacy. This month, we have the honor of speaking with Dr. Namita Goyal, and we will allow her to introduce herself instead of me reading a bio, and then she will share a little bit about her work. So welcome, Dr. Goyal.
Thank you so much. Hi, everyone. I have met many of you through the TMA because I've been a part of the TMA organization since I think 6 or 7 years now. My name's Namita Goyal. I'm a professor of neurology and I specialize in neuromuscular diseases. Myositis is a passion of mine. I really want to help patients have a better treatment journey and a journey really all together. And so I have been doing a lot of clinical trials in all types of myositis, but today I wanted to focus on our work with inclusion body myositis. So I'm going to share my screen and tell you a little bit about what we are doing at University of California in Irvine in IBM, and then also discuss one of the upcoming clinical trials that I'm quite passionate about, and I'll tell you why. So as many of you know, with IBM, it is the most common muscle disease over the age of 45. It's generally considered a slowly progressive muscle condition that affects the quadriceps muscles and the hand grip muscles. And later stages of the disease are often characterized by gait difficulties, motor disability, and swallowing difficulty. Now, the jury is still out as to what the real cause of the disease is. However, when you look at muscle biopsies, you will see both muscle inflammation, suggesting could there be an autoimmune feature, as well as neurodegenerative features, suggesting could this just be a degenerative disorder, or is it a combination of both? Well, there have been some advances, including in 2011, there was an identification of an autoantibody directed against a muscle protein. And many of you may have heard of this, but it's called the NT5C1A autoantibody. And it was initially reported to have a sensitivity or prevalence in IBM of about 60 to 70%. And so our group was very interested in trying to understand why. Why do some patients with this autoantibody have it in IBM and others don't? And so we were the first to do a study where we looked at IBM patients and their NT5C1A antibody status. We looked at several clinical assessments, breathing tests, motor function tests, questionnaires, and we enrolled 25 patients in the study and found out that about 70% of patients were positive for the NT5C1A antibody. What our study concluded and found was that patients with the autoantibody might have a more severe disease. They might have more walking difficulties, more swallowing issues, and even some respiratory involvement. Now, we were the first to report this back in 2016. And so a European group looked at their database and looked at about 300 plus IBM patients and said, Goyal and colleagues seem to be onto something because we found similar findings. They found that patients that had the antibody did have more swallowing issues, did require more aids to help walk. And interestingly, they even saw that maybe patients with the autoantibody seemed to have a higher mortality risk. Now, I will tell you these findings have been contradictory because the WashU group led by Dr. Weil last year, published in 2021, evaluated about 250 IBM patients, and they actually did not find a difference between patients that were positive for the antibody and negative. They did not find a difference in swallowing or a difference in survival. And so this really begs the question of what's really happening. Does this autoantibody reflect disease severity or not? And even more importantly, do we even understand the true disease progression of IBM? This has never really been formally studied until now. We finally, I'm proud to say, have gotten an NIH-funded natural history study led by my colleague, Dr. Mozaffar, and I'm the site investigator here at UC Irvine. And this is a study called INSPIRE, where we're basically trying to understand, can we characterize disease progression better in IBM? We feel like this might be the barrier to drug development. And until we get a true understanding of the rate of how the disease progresses, we will then be able to better develop therapies in IBM. We also want to get a better understanding of what we call biomarkers that are associated with IBM. And that's really just a nice scientific word for saying, what are some influences on IBM that would help understand disease progression and behavior? So we want to look at the antibodies. We want to look at the inflammatory cells in IBM to see if it influences how rates of disease progress. And so we've planned this long-term natural history study. We actually used patient input. We did a patient engagement studio back in 2019 and gained the input of patients to help design the study properly. And the study is ongoing. It's a 2-year study that is done every 6 months. It's very similar to studies that we do here in clinic, where we're just doing a number of physical exam evaluations. We're doing some blood tests. We're doing some questionnaires. And then a muscle biopsy is purely optional, so not mandatory. And then there's several questionnaires that our patients are being asked to fill out. But for those of you that are interested in participating, we are still looking for patients, for IBM patients that are 40 years and older, and if they've had the disease for 10 years or less. Those are the main inclusion criteria that we're looking at. There are several sites across the nation, and I'm proud to state that we now have 2/3 of the study enrolled, so 100 out of 150. We're just looking for 50 more participants. And if you happen to be located near one of these centers that are listed on this slide, please contact our project manager, Marie Wenzel. I have her information here, and I believe she's joined this session too. But we just need a few more patients to complete the study. And what's exciting is that the NIH is finally interested. They are the ones that funded the study. They're interested in understanding IBM, and we're hoping all of this will gain better insight into drug development for IBM. So I'm going to switch gears now and talk about upcoming clinical trial that I'm very excited about. And a lot of this is the work of Dr. Greenberg out of Brigham and Women's in Boston. Many of you may have heard that Dr. Greenberg has sort of evaluated the inflammation in IBM patients. And what he has found is that these inflammatory cells called CD8 T cells express a surface marker called KLRG1. Now, this surface marker is a marker of highly differentiated cytotoxic T cells. And what that really means is these are specialized inflammatory cells that seem to be present in IBM muscle and blood and are thought to have a role in disease causing. But they're so specialized and highly differentiated that we think they don't respond to standard immune therapy, which is why standard immune therapy hasn't really helped in IBM. So we collaborated and worked with Dr. Greenberg and our immunologists and looked at the blood of about 50 IBM patients. And what we found is that this KLRG1 marker is greatest amongst CD8 T cells, and they're also greatest amongst the highly differentiated T cells. We also have found that with longer disease duration, there's greater T cell differentiation. And KLRG1 T cells seem to be present in IBM despite disease severity. So patients with mild disease or even severe disease seem to have this marker. We published these results last year in the Journal of Neurology, and this has generated a lot of enthusiasm that KLRG1 might be a potentially attractive therapeutic target. So Dr. Greenberg has founded a biotech company called Abcuro, and they have designed a drug that they're calling ABC008, but it basically targets KLRG1. It's an anti-KLRG1 antibody that's trying to deplete or reduce the inflammatory cells that are thought to be disease-causing in IBM. So I talked with Abcuro last week, and I asked them to give us an update on the clinical trial, and they graciously provided these slides. So these slides are by Abcuro, and the phase 1 studies are ongoing. They're in Australia. Some takeaway points is that 11 patients have been enrolled. There are 4 sites in Australia, and the purpose of this study is they're basically evaluating safety, but they're also evaluating the optimal dose. They're looking at 3 different doses and how frequent the drug should be given. And so far, what we've preliminarily found out from the phase 1 study is that the drug is being planned on being dosed every 8 weeks. So every 2 months, you would be given the drug. It's given as an injection, so it's not an IV infusion, it's not a pill, but it's an injection that's given under the skin, so a subcutaneous injection. They've so far reported no serious side effects, and interestingly and importantly, they have been able to show that they could reduce the cytotoxic T cells after administering this drug. The 11 participants that are in this phase 1 study are still going through the study, and safety has not been an issue so far. So what I'm excited to tell you about is the phase 2, phase 3 study is about to start. They are identifying and activating sites sometime this spring, so it should be happening very soon. And initially what they're going to do, and this is my last slide, but what they're first going to do is enroll 30 patients, like you can see here in part A. And after those 30 patients are enrolled, they're going to have a safety monitoring board review all the data and make sure that there aren't any safety concerns. They're planning that for the fall. And then hopefully by later in the fall, they're planning on moving on to part B, where the remaining 200 patients are going to be enrolled. So this is going to be a very large study. They're planning total 230 patients with 45 sites across the US, Europe, Canada, and Australia. And they're basically currently looking at 2 doses versus placebo. And the study will last about a year and a half, so 84 weeks. What I know about the inclusion criteria, it's for patients that are 40 years and older that have been given a diagnosis of IBM. And they should be able to arise from a chair without someone sort of pulling them or helping them up. So they have to do it on their own. And they should be able to walk 6 meters on their own or with an assistive device. Immunotherapy has to be washed out. So if someone's on major autoimmune medications, they would have to be discontinued. And it seems like a low dose of steroids are permitted. So I am very excited about this study because it is targeting a marker that for, I think, almost one of the first times we've identified in IBM muscle and blood. And it makes it, I think, a very exciting time. So with that, I am happy to answer questions and talk to you all about this study or other questions you have even about inclusion body myositis. And if we have time, other myositis subtypes.
Yes, if you have a question for Dr. Goyal, please put it in the Q&A. We have a lot of questions that were submitted earlier through email, but we will try to get to as many as we can. We had one come in about where are the clinical trials in Europe?
So I don't have the exact sites listed. If you're asking about the ABCURO study, the ABCURO study is the KLRG one. They did tell me that there are going to be sites in Europe as well as the US, but they did not give me the exact names. And if you look on clinicaltrials.gov, eventually those sites will specifically be listed.
And then how do they ask to be added to the clinical study in the US?
It's probably best to look on clinicaltrial.gov. If you go on clinicaltrial.gov, it's open to anyone, and you can just type in inclusion body myositis, and it'll list the clinical trials. And on there, which I believe I checked, I believe last week, they have not yet listed the sites that are going to be activated, but I'm assuming sometime this March, they will list the sites and the contact number.
Wonderful. This person is not clear on what the findings are for antibody N5C1A. Is it conclusive on progression?
Yeah, that's a great question. And that was sort of the point of what I was discussing, is that we don't have hard data to say that it is conclusive or not. What I was insinuating was that we have some studies saying that patients with the NT5C1A antibody may have more severe disease. However, a recent study out of WashU said we did not find that finding, which is exactly why we've planned this natural history study through the NIH, because we do want to try to answer that question. So you're absolutely right saying that it is not clear, and it's not clear to us as the physicians taking care of IBM patients either.
Okay, why is there a requirement for the ABCURO trial to be able to arise from a chair without support?
That's a question that, you know, companies and investigators all sort of put thought into. Generally, companies will create an advisory board where they get insight from several IBM physicians and then help decide what would be best in designing a study where they can get a patient that is affected, but not so severely affected where we may be dealing with end-stage muscle. So this qualification, there are some stipulations to it. So a patient can use armrests, so they can use their support, but they just can't have someone else pulling them up to get out of a chair, because that may suggest the patient is more advanced and progressed and may have more end-stage muscle damage, which may make it harder to detect if the drug is working or not.
Wonderful. Thank you so much for that clarification. Are there any treatments for those who are unable to walk 6 meters?
That's a great question too. And, you know, currently right now, there are very few drug trials going on. The ABCURO drug trial should be starting very soon. And the only other drug trial that I know of is the rapamycin or sirolimus drug trial, which is mainly happening in Australia. And in the US, there's going to be 2 sites, one at Kansas and one at Johns Hopkins. But I do know that the requirement for that study is that patients do have to walk, do a 6-minute walk test in which they walk at least 200 meters. So
speaking of rapamycin, someone wanted to know if you know of any serious side effects of that drug.
yeah, that's a great question. Rapamycin is an old immunosuppressant drug. It's been around for quite some time. But with strong immunosuppression, there are always some serious risks that can occur. And so we're not advising patients to try to take the drug just because the drug might be available. Right now, I think it's very important to see what the clinical trial results are first before we start telling patients, oh, sure, take the rapamycin drug because it's been around. I think any immunosuppressant drug can have potentially serious side effects, like risk of infection.
Of course, yes. Yeah. Someone asked, why does IBM wind up with the neurologist while other forms of myositis are typically seen by rheumatologists or dermatologists? And are there any differences in how someone with IBM would be treated depending on which specialty they see?
I think that is sort of based on the nature of the different types of myositis. So dermatomyositis and another common myositis called antisynthetase syndrome often has some constellation of symptoms like rash, fever, joint aches. And so oftentimes a primary care doctor might see that and refer them to a skin specialist, such as a dermatologist or a rheumatologist. What's unique about inclusion body myositis is patients don't typically have other systems involved, like skin. And so their primary concern is muscle weakness that progresses. And so usually that falls in the territory of a neurologist. However, I would say that I have seen many, many IBM patients that have seen initially a rheumatologist as well. So I think IBM does fall in both neurology and rheumatology. However, dermatologists typically are not involved because of the lack of a skin rash.
If someone has IBM and is only being seen by a rheumatologist, do you suggest that they then seek out a neurologist?
I think some rheumatologists are excellent. We have many rheumatologists on our medical advisory board, and I think they have a deep understanding of inclusion body myositis. And on the flip side, there are some neurologists I know of that don't really understand inclusion body myositis. So I think what's most important is seeing either a rheumatologist or a neurologist that has a really good understanding of inclusion body myositis, because there are many other issues that should be addressed in IBM while we're waiting to develop therapies. Like, we see a majority of our IBM patients in a multidisciplinary clinic where we have someone evaluating their speech, their swallowing, the respiratory therapist is evaluating their breathing function, and our physical therapist who's evaluating any need for assistive devices for mobility or adaptive equipment at home. So I think really any rheumatologist or neurologist that has built a team or at least has a deep understanding of IBM would be great.
Wonderful. So it's basically physician dependent.
Yes.
Okay. Have you had patients with NT5C1A antibody that don't have IBM but have another myositis?
Yes. If you, I know I showed some of my slides quickly because I wanted to save more time for this Q&A, but the NT5C1A antibody has been reported in lupus and Sjogren's disease. And both of those have been associated with what we call an overlap myositis. However, in those patients, they don't typically have the profound muscle weakness that we see in IBM patients. So we have been seeing some overlap, to summarize, but if you have the antibody, but you don't have profound muscle weakness like we see in IBM, then it may not be IBM.
Among the peculiarities of IBM, asymmetry, right versus left, earlier effect on certain muscle groups than others, etc., it seems that muscles innervated by cranial nerves are less affected, speech, respiration, EOMs, etc. This person can still wiggle their ears.
Yeah. There's different types of skeletal muscle, but I would say that what we have noticed is that the facial muscles actually do get affected in IBM, but a varying degree. Some patients don't have much involvement. Other patients actually do have difficulty completely closing their eyes, and do have difficulty sort of puckering their lips. So we do see some variability in facial muscles, but yes, the extraocular movements or the eye movements seem to be spared. And we are trying to get a better understanding of this through our natural history study, because we are evaluating the facial muscles as well as the arms and legs, and speech and breathing.
We have been focusing on questions submitted live through the Q&A, so I'm going to switch over to some of the ones that were submitted before. And you may have touched on this in your presentation, but have you learned anything about the amount of antibodies versus disease progression since the antibody was first discovered?
Yeah, I think we've discussed this, where we're still trying to, the conclusion is that we're still trying to gain a better understanding. We are measuring both the antibody positive level as well as the titer in our natural history study. And we are going to be, analyzing that data and publishing that data once the study is complete, so that everyone can gain a better understanding.
Thank you so much. This person asks, how close is the IMAX group to developing a core set of measures for IBM clinical research?
There's a lot of work going on in IMAX, and what I'm happy to report is I am part of a subcommittee. There is a subcommittee just focusing on IBM and different outcome measures, specifically looking at IBM and which ones would give us more information than others. So the group has been formed, they meet regularly. And then again, that's another reason why we are doing this natural history study, because we are looking at several of these outcome measures to see if we can design something better, or if there are optimal measures that we already have.
For those in our audience that don't know what IMAX is, can you give just a brief description of it?
It's a group of specialized experts, rheumatologists, neurologists, really those of us that have specialized in myositis, also other subspecialties, as you know, pulmonologists, dermatologists, really a group of specialized individuals that are very interested in developing and advancing the research of myositis. That's sort of the short, condensed summary of
yes. Thank you so much. For people with IBM, and forgive me if I mispronounce these, how does beta-alanine and beta-hydroxy-beta-methylbutyrate, I knew I was almost there, I almost had it, but HMB for short, help muscle fibers recover from exercise?
I don't think there's great data yet, or conclusive data on suggesting the influence, especially in IBM. I know there's a lot of supplements and a lot of research going on, but it's hard to make major conclusions in IBM, because what we do know is that the condition seems to be so variable. I have some patients that have had IBM for 20 years and have mild disability. And unfortunately, I have some patients that have had it for 5 years with much greater disability, and then vice versa. And so, to make large conclusions about some of these drugs and some of these supplements have been very difficult in IBM, because until a larger study is done that formally evaluates the different muscle function, it's hard to say.
In your practice, have you seen that individuals that are in high stress positions like the military, air traffic controllers, medical, or police have a higher incidence of developing IBM, ALS, or other rare neuromuscular disorders?
Yeah, we talk about this actually quite frequently. I go to all the national, international meetings, and we certainly don't discount stress. We do think that stress plays a role in developing, many of these serious neurologic, rheumatologic conditions, autoimmune conditions. Can there be a trigger? It would be nice to try to identify it and characterize it better. But I certainly don't discount stress, and I do think that stress can play a role.
We have some people in our audience that are curious about the findings of Dr. Lloyd and Dr. Todd Cohen about the similarities between ALS and IBM. Do you have any comments about that?
Yeah, one of my other passions actually happens to be ALS. And so I also do several clinical trials in ALS. And if you guys remember, a few years ago, there was a clinical trial being done with arimoclomol. Arimoclomol was being tested in inclusion body myositis, and the same drug at the same time was being tested in ALS as well, because many scientists have thought, could there be a common pathway, especially when we talk about the neurodegeneration that might be happening in both ALS and in IBM. Now, unfortunately, the arimoclomol study was negative in both diseases, so we don't have a clear answer why, but we do wonder at times if the conditions do have some common pathway higher up and then separate it out further down.
Someone wondered if neurologists might have an edge in IBM due to referring doc concerns for ALS. Do you have a comment on that?
If neurologists have an edge to identifying IBM?
Perhaps the difference.
Okay.
I know that we have a lot of people that are misdiagnosed with ALS, and then later they find out that they're IBM. I don't know if the reverse occurs.
Yeah, no, I mean, I think it's true that in general, neurologists might see IBM more just because of, again, the motor weakness that develops. And, some patients wonder, could this be ALS? Could this be IBM? And that's probably because what's different about IBM from the other myositis subtypes is we do see profound muscle atrophy in IBM, which we typically don't see in dermatomyositis or antisynthetase syndrome. And so it's true that sometimes some patients may be confused as, and given a diagnosis of, could this be ALS or could this be IBM? Because in both diseases, we do see muscle atrophy, especially in the quadriceps muscle. However, I would say that the NT5C1A antibody has been a very useful blood test for helping sort out the two conditions, because the NT5C1A antibody has almost been used as an adjunctive diagnostic test in helping confirm the diagnosis of IBM. And we typically don't see it in ALS patients. And there are reports in the literature about almost a 5-year diagnostic delay for IBM patients because they just don't have all the classic features at times. But we're hoping that this blood test with the NT5C1A antibody sort of reduces that diagnostic delay.
We have several questions about diet and exercise regarding disease progression. Are there any studies on that? What is your opinion? Do you have any recommendations for supplements or a diet specifically?
Yeah, no, these are very, very important questions. Until we find a cure or a treatment to even halt progression in IBM, I think it's really important to think about exercise and diet. We actually have some physical therapists that are on our medical advisory board because we all feel that physical therapy or some role of exercise is quite important in inclusion body myositis. And because the condition is so variable with many patients, it's been challenging for us to say, do this exact exercise for this amount of time. But there are some guidelines that we do provide. We do know stationary cycling is a good form of exercise. We do know aqua therapy is a good form of exercise if you can get safely in a pool. During the pandemic, when it was hard to go to the gym, I would tell patients, and my physical therapist would tell them, buy some pedals off of Amazon, those stationary pedals, and you can just use those pedals. I'm told they're only $20 or $30, and you can use them with any chair and pedal for 15, 20 minutes. But I usually tell patients some guidelines like no pain, no gain is not the motto here. So you don't want to exercise to the point of muscle pain or fatigue. If you're exercising one day for 15 minutes and it felt great, and so the next day you say, I can do 30 minutes, and then you exercise for 30 minutes, but then the following day you say, I can't get out of bed because it feels like I just did too much. My muscles are hurting. I'm fatigued. That is too much. And so you do have to listen to your body and cater the exercise to what feels good, but is not causing severe muscle pain or fatigue. And then generally we tell patients, we don't want you weightlifting or bodybuilding. That's not really the point. The point is stretching, range of motion, and some form of cardio that feels good, which oftentimes can be through stationary cycling. Walking is a great form of exercise. If you can walk with, and you need a cane or a walker, we just don't want falls. And then as far as diet, I usually tell, we don't have great controlled studies giving guidelines on diet, but a few things that I tell my patients is, watch your weight in terms of weight stability is helpful. We don't want you gaining excess weight. At the same time, we don't want you losing excess weight, because sometimes when you lose excess weight, the muscle might come off too. And so weight stability is a helpful guideline. And then I have some of my patients that are interested, while none of these are published supplements, creatine and coenzyme Q10 have been some supplements that I know many IBM patients have explored. I usually tell them, follow guidelines, talk to your CVS pharmacy or something over the counter and just take a moderate dose. I believe in nothing in excess. And I also believe in a well-balanced diet.
We had several questions about evaluating and managing diaphragm weakness in later stages of IBM. What percentage of IBM patients have diaphragm weakness?
Yeah, that's really important. So I'm glad this question was asked because in our clinic, we do have a respiratory therapist, and all of our IBM patients get pulmonary function tests about every 6 months. If you don't go to a clinic where they have a multidisciplinary team and a respiratory therapist, then we do suggest having maybe your neurologist send you to get pulmonary function tests at least every 6 to 12 months. And then there's some guidelines that if we measure what's called the forced vital capacity. The forced vital capacity is given as a percentage, so 100% is perfectly normal. And by Medicare guidelines, if the forced vital capacity is 50% or less, we generally recommend starting patients on non-invasive ventilation called BiPAP. So similar to patients with sleep apnea, they use a CPAP machine. A lot of IBM patients can benefit from using a BiPAP machine if those breathing numbers are 50% or less. We do see in advanced stages of the condition that respiratory issues can be one of the leading causes of significant morbidity and even mortality in IBM. So this is why we monitor patients every 6 to 12 months, because we want to make sure that their forced vital capacity is treated early with non-invasive ventilation. There are studies that suggest that if you use BiPAP when it's indicated, when it's needed, meaning it can slow down the diaphragm involvement. For those of you, just to remind you, the diaphragm is a skeletal muscle that does get weak in advanced cases of IBM patients. And so we try to support that by using BiPAP as a method to help slow down that weakness.
What is the mechanism of dysphonia in IBM?
So dysphonia, again, is, it's complicated because there are several muscles involved in our speech that help us articulate. There's the lip muscles, there's the tongue muscles, there's the palate itself. And all of these muscles, to some degree, may or may not be affected in IBM patients. Some patients have the disease for 20 plus years without dysphonia. Dysphonia, for those of you that don't know, just means that the speech becomes quieter, it can become softer, it can become a little bit harder to articulate. But in some patients, those muscles can be involved and the speech can be affected because of that.
How common is it? Because, I mean, my personal experience, I haven't seen it very often. And so I was wondering, is it rare?
Yeah, I mean, it's not, it's definitely not a common initial symptom. But again, we're still trying to understand the variability of it. It's almost similar to the variability that we're seeing with swallowing difficulties. I've seen published reports that 1/3 of patients with IBM will develop swallowing difficulty. However, we know that later on in patients with very severe disease, and even sort of what we might say as end stage IBM, where patients have such severe weakness that affects all of their arms, all of their legs, their diaphragm muscles, we will see some with speech involvement. And in those cases, a majority of patients can have swallowing involvement. But you're right, it's definitely not a common initial symptom, and it's definitely not a common symptom, but it can be affected when the facial muscles are weak, as well as, remember, the diaphragm also contributes to our volume. If our diaphragm is weak, then we can't have a large volume and phonate quite loudly. So in those situations, the voice can also be affected.
Thank you. We had questions about medications for IBM. Somebody has IBM, but they're on prednisone and mycophenolate anyway. And should they, I mean, you don't know all the details, so you can't tell
Yeah.
them if they should stop or not stop. But what is what is in your practice as far as that? Do you try them out just to see if they might work, or do you not bother with them?
Yeah, that's a great question. I think there have now, I used to give this talk on all the clinical trials that have been done in inclusion body myositis. And there have been actually controlled trials looking at prednisone, looking at methotrexate, looking at azathioprine, IVIG, Cellcept, and mycophenolate. And unfortunately, none of those have shown robust data that could slow down IBM progression or stop the disease or reverse the disease. And because of that, the common practice with many of us IBM specialists is when we make a diagnosis, we don't start one of these medications. Now, there are some reports of some patients saying that, oh, they were on prednisone and they actually felt better or they felt stronger on that. So in those cases, we do think that there are some individualized situations that happen. And I think it's really important to discuss with your neurologist or rheumatologist that is seeing you to ask them if they think that there is truly a role in starting prednisone or Cellcept. But the common practice amongst many of us IBM specialists, and certainly on the medical advisory board, is after we've given a diagnosis of IBM, we don't typically start one of these immunosuppressive medications, since the studies have all been negative and showing robust effect on IBM. Go ahead. Yeah.
Okay. So a lot of our questions have been a little bit, advanced as far as there's, a glossary, which we do have on our website. If there's any newly diagnosed people in the audience and you're kind of feeling overwhelmed, the next question is for you. We've got someone who's recently diagnosed with IBM. He shows weakness in his arms and legs. And what would you recommend to your patient for the first means of action?
Yeah, that's a great question. By no means, I'm going to take a step back hearing Rachel's question, because by no means do I want to overwhelm anyone. I want this to be informative. And I think the most important thing to remember when you have IBM, and really any myositis subtype, is no one patient is similar to the next. We have seen so much variability in IBM. So if you like to Dr. Google things, and I don't want you to see all these pictures of IBM patients and think that because some patients are in wheelchairs, that means that's going to happen to me. It doesn't happen to everyone. In fact, there was one study that showed only 11% of IBM patients were in a wheelchair.
I'm sorry, I missed that. Did you say 11%?
11%. This was one study. And again, that's sort of the purpose of our natural history study that we're doing, is to really understand and address the question of what's the true percentage of patients that are using different types of aids with walking. But what I tell my newly diagnosed patients is I actually love the TMA website. I think it's a wonderful patient resource. And so I often will tell patients, rather than Dr. Googling things and seeing all different kinds of medications, trials, supplements that should be done, I think the Myositis Association has done a nice job of giving patient information. The patient information on the website is designed and by the input of the medical advisors. So these are all from physicians and specialists who have seen and understood IBM, sometimes better than Dr. Google. And I also tell patients that no one condition is similar to the next. And really, it's really over time and monitoring you every 6 to 12 months that we're going to be able to understand how fast you're progressing. Like I mentioned, some patients over a 5-year period, we've barely seen much progression, and in others, we do see progression. So my advice is find a specialist that you feel comfortable with that can help sort of understand your progression and how you're progressing or not, and monitoring your respiratory issues if there are any, and your swallowing issues, because those two conditions can lead to trouble, like aspiration pneumonias, or make you more sick than the disease itself.
Have you seen any patients who have stayed physically independent after having IBM for over 20 years?
Oh, yes, I have. I can think of several patients in my mind, and I'm smiling because I've been thinking of their face and the discussions we have in clinic. And, you know, I have an 80-year-old patient that walks in maybe with a cane just for a little bit of support. But he continues to be independent and drives and does all of his activities and has had IBM for well over 20 years. And so that's why I think it's very important to remember that IBM is a special condition where there is so much variability. And
because of that variability, you might not know the answer to this question, but of that 11% that you referenced, do they reach it at around the same time, 5 years, 10 years, 15, 20, or is there a lot of variability within that 11% also?
Yeah, there is just so much variability, which is why we believe that we don't still have a good handle on the rate of progression for IBM. And we're trying to figure out if there's characteristics that might influence the variability. What we have seen sort of overall is that longer disease duration does seem to correlate more than other factors with that 11%. Like I would say it's rare for someone with the condition in the first 2 years to be using a wheelchair.
For individuals with IBM who are unable to walk, what is the effectiveness of using an EMS TENS unit along with muscle contractions? Are there benefits and/or cautions?
Yeah, I've heard this question a lot. For those of you that don't know, a TENS unit in simple terms is basically electrical stimulation that a lot of physical therapists use sometimes to try to stimulate the nerve and the muscle. It's more commonly used in patients that have had like a nerve injury or a spinal cord injury. It's less commonly used in a muscle condition because we just have not seen, again, robust data suggesting that it's helpful in IBM. At the same time, I've never really heard of reports saying that it worsened the condition. While I'm not encouraging patients to go out there and get it, I'm just saying that we don't have strong data either way suggesting it's helpful or harmful.
Are IBM muscle cells normal until IBM attacks them? That's what the question was.
Oh, that's a great question. I think that's a question we're all, even as researchers, trying to understand that, you know, what I did show you, and again, it was a slide that I flashed up very quickly. When we did the study with Dr. Greenberg, looking at the surface marker of KLRG1, KLRG1 is present on what we think are highly differentiated inflammatory cells. We did find that it seems to be greatest with longer disease duration, but we see it despite disease severity. So some patients with even mild disease show that the KLRG1 is present both in muscle and in blood. But long story short, I don't think we all as researchers even have the answer to the question if the muscle starts getting affected even before we can detect clinical weakness. We think that might be the case because the disease seems to progress so slowly. And we've actually had a few interesting cases at UC Irvine where a patient was sent to us with high CK or muscle enzyme levels, but no muscle weakness. And then we've also sent the NT5C1A antibody in them, and we found that it was positive. So we're starting to wonder, does the muscle start getting affected even before someone manifests with muscle weakness? I think that's a great question that we're still scratching our heads for.
And I understand where you are. It's your lunchtime, correct? So do you have a hard stop? I forgot to ask you before we started.
I just probably have a patient around 1:15 or so.
So we have time for a few more questions.
Yeah,
Okay.
maybe another 5-10 minutes. I'm happy to.
Okay, thank you so much for taking your time. You did get a chance to eat something, didn't you?
I will. Eating
You
is
promise?
hindsight. What's important to me is really helping patients with this journey. I know this journey is just so frustrating, and it really gets to my heart when I hear patients have been misdiagnosed or, not greatly managed. And I just want to do my best in trying to spread that information so that every patient really has the opportunity to have a better course.
Well, someone wrote in to thank you for your time, passion, and the wonderful opportunity to learn and be better informed. They appreciate it, and they think you are awesome, as we all do. So thank you for taking time on your lunch break to speak with us today. Since we've got a little bit more time, has there been any findings on heavy metal toxicity, specifically arsenic, in IBM, either as a cause or contributing factor? Example, 24-hour urine collection, hair, nails, that type of thing.
Yeah, I mean, great question again, because it's been studied, it's been looked at, but again, not in great detail, and also not with any hard data suggesting that there is a link. I know in our natural history study, we are looking at urine, and the buzzword here is biomarkers. People love that word now, us in science, and basically that's just a medical term for saying we're looking for links of what could be either causing disease or either influencing disease, so that why does someone have a faster progression than another? But we don't really have any hard data suggesting heavy metals might influence disease.
What is your opinion on alternative medicines like acupuncture and homeopathy?
Yeah, I actually think that's a great question too, because we all know acupuncture is part of, Eastern medicine. It comes out of China. It's being done for centuries, and we've never medically heard any harm in acupuncture. And in fact, at UC Irvine, we have a new integrative health science clinic where they're actually incorporating acupuncture. I actually happened to meet with them earlier today at 7:30, and they were telling me that they have this 85-year-old Chinese physician that does acupuncture, and a lot of patients report that it feels good. They overall feel well. I can't say that it actually helps slow or stop disease, but I've certainly never heard harm. And if patients are interested in trying it, as a physician, I tell patients I'm okay with that. I don't see any harm to it.
Have you heard of people being misdiagnosed with necrotizing myopathy, but they really have IBM?
Yeah, I do think that many patients get misdiagnosed as another subtype. And I do manage several patients with necrotizing myopathy. There are an astute physician that sort of knows the exam very well in IBM may be able to help detect the difference between the two, but oftentimes necrotizing myopathy patients will present with weakness that affects the hip girdle muscles and the shoulder girdle muscles first. They rarely have what we call finger flexor involvement, where they have difficulty making a grip. The challenge is in early onset IBM patient, not all patients early on in the disease course will have grip involvement. And so patients will often be misdiagnosed as either polymyositis or necrotizing myopathy because they will have the hip girdle muscle weakness and the shoulder girdle muscle weakness. I certainly have met many patients over the years that came to me with the diagnosis of polymyositis. And unfortunately, I walked in the room and, examined them carefully, and I examined their finger flexors carefully. And I said, this does not look like necrotizing myopathy or polymyositis, but in fact, it looks like IBM. So sometimes it just takes the careful examination. What I tell my patients is there's a few things we can do. I do recommend doing an antibody blood test. There are now 2 specific antibodies that are found in necrotizing myopathy, and there's the one antibody found in IBM. So I tell patients they should always try to ask their physician for the blood test that could help see which antibody they have. The antibody itself will be helpful in distinguishing which subtype. And then, we still use a muscle biopsy to look for some key characteristic features that would distinguish between necrotizing myopathy and IBM. And there's some specialized stains that can be done on the muscle to distinguish the two.
As our final question, I'm sorry we couldn't get to everyone's question, whether it was in the Q&A or submitted by email. We will save them for future Ask the Docs. But let's talk about pain in IBM really quickly. What percentage of your patients experience pain, and how do you advise them to manage it?
It's like I planted that question. That's great. It used to be thought, and it breaks my heart to even say this, it used to be thought, oh, IBM patients don't have muscle pain. This is a painless condition. And so we noticed at UC Irvine that patients would get frustrated hearing that because many of our patients would complain about pain. And so we actually did a study looking at pain in our IBM patients, and it was through a survey, I believe. It was a few years ago. And Rachel, we could try to at least send you that abstract if you wanted to send it out to the audience. But we did find that a good percentage, I don't want to be misquoted, so I'm not going to give a percent, but we did find that a good percentage of patients actually did suffer with pain. And I try to make sure to now discuss pain in IBM and not dismiss it as a feature that's not associated, because we do see that in IBM patients.
Thank you so much. I really appreciate you taking time to be part of our webinar this month, and we look forward to hosting you on other educational programming offerings we have. So thank you so much, Dr. Goyal. And thank you to those of you in the audience. Did you have any last words you wanted to share?
I just wanted to say thank you to the audience. And I really believe that the way that we're going to find a cure and develop drugs in IBM is participating in clinical trials. So if you can, and if you're close by one of our natural history study sites, please participate, because we're very close to finishing that study. And then I'm excited. I want to end with an optimistic note. I think that drug development is happening faster than I've ever seen. And I'm excited about the future of IBM, because I truly believe we're going to find a better therapy. So thank you, Rachel, too.
Oh, that is wonderful news. We are so happy to hear that in 2023. Thank you for being part of our webinar, and we will see you again later on in the year. And thank you for joining us for our Ask the Doc webinar series. My name is Rachel Bromley, and I'd like for you to tune in next month. We have a new offering for you. It's a myositis research webinar where researchers get to explain what they're doing and how they are furthering the cause for myositis. And on March 14th, we will be hosting dermatologist Dr. Victoria Worth. So please tune in for that. Thank you so much. I'm Rachel Bromley. Good night.